Video content or information here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Please also see the written disclaimer with more details below. Thank you. Hi, I'm Dr. Carrie Bennett, and in this video, I'd like to talk to you about atypical lobular hyperplasia and atypical ductal hyperplasia. Atypical means cells that look abnormal when the pathologist looks at them. Lobular means that they look more like your normal lobular cells, and ductal means they look more like your ductal cells. Hyper means increased, and plasia means growth. So it's abnormal growth of the duct or lobular. Again, remember LCIS, and you can look at that video, is not a cancer, but a marker that you have a 10-fold increased chance of expressing breast cancer in either breast as you age. And that pathology follows the normal pathology, with 80% of people presenting with a ductal tumor and 20% of people presenting with a lobular tumor. With atypical lobular hyperplasia or atypical ductal hyperplasia, known as ALH or ADH, you therefore also are considered high risk in the future throughout all of the tissue of your breast for future breast cancer. And your doctor may add MRI screening in with your mammogram screening, like we do with LCIS, or someone who's genetically positive, like a BRCA gene, BRIP1, CHEK2, or something like that. ALH and ADH increase your future expression of breast cancer, as I said, by 4 times that of the general population. So when you get diagnosed with one of these atypical types of cells on core biopsy, you always have 4 options. One is to do nothing, which is usually not recommended. Another is to sample the tissue, which usually you've already done to get the diagnosis of ALH or ADH. So then you're really left with 2 options. One is to follow it radiographically, and another is to excise it or go to the operating room and take out that tissue. While in the past, we always took out during an excisional biopsy for ALH or ADH, we no longer always do that. We base it on an individual basis based on what we see on the mammogram or ultrasound, the pathology, how big it is, whether or not it's been fully removed by the incisional or core biopsy, your age, medical problems, and things like that. We will help you decide whether or not we think it's best to follow this with future mammograms and or ultrasounds and possibly an MRI. Or sometimes we take it out, and often we take it out at an excisional biopsy, which does require a full operation. Again, we put back the tissue, hopefully in a beautiful way with the oncoplastic techniques, and also try and hide the scars. Also, one of the things we do with patients who have atypical cells, like atypical lobular or atypical ductal hyperplasia, is we will send you to see the medical oncologist, usually after excision. There can be an upgrade rate to cancer, often a DCIS, but sometimes more rarely an invasive cancer at the time of excision. So often that's why we take it out. Some people believe that ADH can become DCIS and then invasive cancer, while ALH is more like LCIS and just a marker of disease. So at the time that we take it out, of course, we'll look at it pathologically, and then if it remains only ADH or ALH, we'll then send you to the medical oncologist to talk about other risk reduction strategies. Now, please refer to my talk on the breast health sheet, because that refers to all the lifestyle changes that we recommend for people. The most important being walking outside for 30 minutes every day, but the high fiber, low fat diet, drinking a lot of water, minimizing sugary drinks, getting that exercise, washing your deodorant off at night, not wearing bras made of underwire or very stiff cups. Those are the things that we recommend for lifestyle changes. But the medical oncologist will talk to you about possibly taking a pill, like we do with our cancer patients, to help reduce your future expression of breast cancer. And we may add in the MRI screening. Certainly, you should continue to do the self-breast exams and have a clinical exam done by a clinician at least once a year, if not twice a year. Now, one thing I'd like to mention that's separate from ALH or ADH is something called FEA, or florid epithelial atypia. Now, it has the same word, atypia, in it. When the pathologist looks at the slides, the cells can look atypical. So instead of being the normal sort of square or columnar type of cell, the cell will look very flat. Lobular and ductal tissue is epithelial tissue. So flat epithelial atypia. That is a completely separate entity. And even though it has a similar name, it is not associated with an increased future risk of cancer and does not need excision at this time. It has not been shown to increase your future risk of breast cancer. So flat epithelial atypia, you would just have normal screening. I hope you've enjoyed this discussion on some of the atypical cells that we see in breast disease.